May I now request Dr. Arif to talk on genetics, ocular genetics for the pediatric ophthalmologist. Dr. Arif is a senior consultant ophthalmologist at Cleveland Clinic, Abu Dhabi. Dr. Arif.
Thank you, Dr. Sumita. Thank you, Dr. Rohit, for having me as part of this symposium. It's my pleasure to be here and my pleasure to speak about this topic. So my time is limited, so I'm going to go through 3 scenarios that are applicable to pediatric ophthalmologists no matter where you practice if you're seeing any volume of patients. The first one is exemplified by this 4-month-old boy. He's the one of 4 siblings. Parents are not related, referred for nystagmus. We examine him. He has no iris. He has peripheral keratopathy. He has a lens opacity. There's no fovea. This, of course, is classic aniridia. Now, I'm a big fan of genetic testing, but I admit that most patients don't need genetic testing for medical management. However, there are exceptions, and I would say this is one of the exceptions where genetic testing is medically indicated. Not so much to see whether or not this child has a PAX6 mutation. Of course, PAX6 is the most common cause for classic aniridia. But to see whether or not this child, who is a sporadic case, has a deletion that's large enough not only to hit PAX6, but also the neighboring gene WT1. If that happened, then he has a predisposition for Wilms tumor of the kidney. And sure enough, when we do genetic analysis, he has a large deletion. It includes WT1, and he goes on to develop Wilms tumor of the kidney 1 year later. But because he was being followed closely, because we expected it to likely happen, it was able to be managed aggressively. This is an ideogram of chromosome 11, PAX6 sits there. The mutations in PAX6 cause classic aniridia. But the important point that all ophthalmologists and actually all medical specialists talk about is that it sits next to WT1. If you have a large new deletion, you can hit WT1 and have a risk for Wilms tumor. This is a classic contiguous gene syndrome. We really have to be aware of this as ophthalmologists because no one is as tuned to this as we are. Here's an infant girl with oculocutaneous albinism, referred because she had cataract surgery and she failed to wear her aphakic contact lens. Here she is. One eye, she's aphakic. The other eye, she has a mild lens opacity. She has albinism. We have the gene mutation. Genetic testing was done. But why did she have cataract? That's not part of albinism. And why does she have lack of iris? Any patient can get a new deletion, even if they already have a different genetic disease. And sure enough, when we do genetic analysis on this patient, who already had genetic testing for albinism but didn't have this test, we find there's a large deletion on 11p. And when we palpate the abdomen, there's a Wilms tumor that even an ophthalmologist can detect, unbelievably missed previously. So we really have to be aware of these kind of things. If we aren't, nobody else is going to pick these kind of things up. Most classic albinism is intragenic PAX6 mutation, so it's not associated with this risk, and it's hereditary. And this is the first concept I'd like to go through. Wagner syndrome and PAX6 mutation in general should be on our radar as pediatric ophthalmologists. The next scenario is exemplified by this child with corneal haze, who was sent to me for glaucoma surgery. Now, I don't have pictures of the corneas to show you, but I have pictures of the face. And because time is limited, I'm just going to tell you, these facial features are very coarse. And this patient has an undiagnosed mucopolysaccharidosis. Patients with some forms of mucopolysaccharidosis come in with corneal haze. And again, we pediatric ophthalmologists are more tuned to this and able to pick it up earlier than anybody else. And why is that important? Some of these forms of mucopolysaccharidosis are amenable to treatment. And the earlier they're picked up, the more efficient the treatment. Here's another patient came in with corneal haze, referred for possible glaucoma. Can you see those facial features? It's an undiagnosed mucopolysaccharidosis. And another one referred with corneal haze, undiagnosed mucopolysaccharidosis. Now, if a child has severe mucopolysaccharidosis, nobody's going to miss that something is wrong. But there are a lot of attenuated forms out there where it's not so obvious. And here's where we come in and are able to detect these patients more easily than anyone else. Excuse me for showing an adult in this pediatric ophthalmology symposium, but I need to show you this case. He's a 33-year-old male referred with burning eyes. He's got short stature, hearing loss, sleep apnea, asthma, bilateral carpal tunnel syndrome, and he has mild corneal haze. He has an attenuated mucopolysaccharidosis that was missed for 33 years of his life because nobody put all of these things together. What's the big clue? The corneal haze. When you look at features of attenuated mucopolysaccharidosis, corneal clouding is way up there as one of the signs. Again, we as pediatric ophthalmologists able to pick this up and suspect it better than anyone else. Final scenario I'd like to share with you is exemplified by this 3-year-old girl referred for low vision, nystagmus, and abnormal head position. She has oculocutaneous albinism. You're a good pediatric ophthalmologist. You can pick this up pretty easily. However, we're not done. We have to ask some pointed questions. And we ask this patient, this family, about any bleeding tendencies, and she bleeds so easily. This patient has one of the most common syndromic forms of oculocutaneous albinism, Hermansky-Pudlak syndrome. Now, depending on where you practice, this may or may not be common. In my patient population, it underlies a surprising number of patients with oculocutaneous albinism, important to pick up because these patients are prone, depending on the type, to fibrosis in organs such as the lung and the liver, and you want to pick these up patients early for anticipatory management. They're all over the world, though. Depending on where you practice, they're more common than others. Here's another girl referred for low vision, no problem in diagnosing her with oculocutaneous albinism, and sure enough, the pointed question, she's easily bruised, genetic testing, she's got Hermansky-Pudlak syndrome. I'd like to close with one other point about oculocutaneous albinism. It's very easy to recognize obvious oculocutaneous albinism. A layperson can do that when they're albino, when they're very white, the hair is white and the skin is pale, and they have these retinal findings. But milder cases of oculocutaneous albinism and X-linked ocular albinism are easily missed. And again, this is something that needs to be on our radar. Here's a girl with nystagmus and low vision. She's had MRI because unable to understand why she has this thing. And when we examine her, she doesn't look like she has oculocutaneous albinism, but if you compare her to her siblings, she's much lighter. And this is the point. There's such a variety of variable expressivity in oculocutaneous albinism. Patients don't always look very pale. And sure enough, when we do iris transilluminations, it's very obvious. But if you don't look for it, you're not going to see it. She underwent all sorts of unnecessary neurological studies because of nystagmus and unexplained reduced vision. Here's a 14-year-old boy with nystagmus and low vision, a similar story, had MRI, neurological evaluation, nobody could understand what was going on. But when we take a good family history, we see that there are multiple people with nystagmus in the family, and they're all males, and it's X-linked. This is screaming at us, X-linked albinism, ocular albinism. Ocular albinism is X-linked. And there's usually someone in the room who can help us with this diagnosis without even doing any genetic testing. That's the mother. And when we examine the mother, who's asymptomatic, you can see this peripheral modeling in the peripheral retina, which is a carrier sign of X-linked albinism. It shows up a little bit better on the autofluorescence. These streaks, that's classic, this mud splattering. We see this in carriers of X-linked albinism, the mothers. So with that, I'd like to conclude. Genetics, you cannot escape it in pediatric ophthalmology. In the limited time I had, I've gone through 3 scenarios, which I feel are important and common enough that we all need to be aware of them. Thank you very much.
Now the floor is open. We have around 5 minutes. If anybody wants to ask any question, please go ahead.
I have a question to Dr. Arif. Thank you, sir, for the amazing talk. My first question is regarding the aniridia cases that you showed. Is there any age criteria that we should, like, before this age you have to get it done, the genetic analysis, to rule out the
Thank you for the question. Most of the patients, nothing is absolute, but most of the patients will develop it before 5 years old. So if I had a teenager who came in, I would not do
All
it.
right.
But it's all statistics. The majority of them will develop it by 5 years old if they have a WT1 mutation. There may be some outliers. But if you have an adult or a teenager, I wouldn't consider it.
And sir, the term that you used, attenuated mucopolysaccharidosis, so is it like it means the missed, like we missed it, or it is some gene, different kind of
You can think about it that the physiological defect is not severe enough to cause an obvious phenotype, but there are still changes that are subtle that might be passed off as normal. I showed you one extreme case there, that nobody is going to think that that child looked normal. But some patients just have some mild coarse features, and maybe people just think this is a variation in racial features or something. What's the clue going to be? The corneal haze. Sometimes it's not severe. Sometimes it's mild corneal haze. It's not even affecting the vision that much, but it's there.
Okay, and if that adult male had received some treatment when he was a child, he would have been better off by this age?
It depends on the form. Not all forms have treatment, but yes, definitely.
Thank you, sir.